so their kilo class is higher. They are likely to have more severe chest pain in the past, and they're more likely to have had prior events in the past than men as well. And again, very sad statistics here. They're less likely to receive anti-cholesterol drugs called statins than men are after they've had a heart attack. They're more likely to have continued angina or chest pain after an intervention than men are. 57% versus 47%. And they're more likely, again, to suffer death from their heart attack. Again, here's how long women took to present, 374 minutes compared to 306 minutes. Again, losing almost a whole hour, again, that golden hour of presentation time. There, again, were less likely to receive these angioplasty and stents by almost 30%. So that's 71, means almost 30% less likely to receive one of these stents. And they were more likely to have a critical blockage in one of the main blood vessels, the anterior descending instead of the right coronary. Younger women who present with this, again, are, as you would think, are more likely to have many risk factors, diabetes, than older women that present with this, and they're more likely to present with major complications like low blood pressure and heart failure. And you can see here women surviving much less than men when they present with their heart attack. So the idea with all this is prevention. You don't want to wind up in the emergency room and see my face at 3 in the morning with either a man or a woman, because that's the end of this game. We really want to attack this at the beginning of the game, and that's where these Class 1 recommendations are coming out from the American Heart Association. Obviously, number 1 is this one here, heart-healthy diet, weight loss, and no smoking. You just saw the diabetes trend. You've seen the obesity trend. There's the same inactivity trend when they've looked at exercise ratios. Only about 10% of people will get the recommended 30 minutes of exercise daily. That's a lot of hours in the day, and we're only asking for 30 minutes of it to be directed towards exercise, and only 10% of the U.S. population gets that in. For rehab for all women, if they do develop a problem, cardiac rehab is highly recommended. Blood pressure optimized, keeping your blood pressure down to 120/80 range or below. Getting people on aggressive cholesterol management based on where their risk factors are. Of course, controlling diabetes and making sure it's well controlled. Aspirin for all women that are at high risk. Even women who are smokers and diabetes without coronary disease probably ought to be taking a baby aspirin, although the dose on aspirin is different for men and women. For women, 81 milligrams is the most that you want to be taking on a regular basis because the risk of bleeding is substantially higher at adult strength at the 325 milligram compared to men. And then, of course, getting people on the right medications after their heart attack. 1 in 3, and then 1 in 3 of those 1 in 3 filling their prescriptions is just unacceptable. So getting people more involved, of support, there's all kinds of support groups for breast cancer, for colon cancer, for stroke victims, but there's not the support that we need out here for women in heart disease. It's a silent killer, it gets brushed under the rug, and we don't have it's not the dinner room table that we're able to have the conversation about it. And that's why those prescriptions, especially in hard economic times, don't get filled. They're the last ones to get filled. They fill their husband's prescriptions before they fill their prescriptions, and they come in with cholesterol's high, and you're wondering why. And so that really needs to change. We really need to kind of incorporate that into the community-wide conversation. Some interesting kind of tidbits. We're always looking at some of the stuff on U.S. news and the evening news. But one of the more interesting stuff out there about diet right now is this Mediterranean diet. You've probably all heard of it. It's not exactly new news, but some of the more recent literature about it is very strong in support of it. They've done 2 major studies, the Lyon Heart Trial as well as the Emory Twin Trial. And both of those, the Emory Twin Trial is what you would think. They had identical twins, and they had one group go on this Mediterranean diet, one just go on the American Heart Association diet, so not a junk diet, a good Heart Association diet with low saturated fat. Even with that, there was still a 10 to 15% reduction in death rate on the folks that were on the Mediterranean diet compared to those that were on the standard American Heart Association diet. And why that is because it's harder to continue the American Heart Association diet. It's a very low-fat diet, 25% fat or less, whereas the Mediterranean diet is nearly 40% fat. but it's good fats, it's not bad fats. It's fats coming from plants, not animals. So non-inflammatory fats as opposed to saturated, very inflammatory fats. What is it? Well, 9 servings of fruits and veggies a day. Average in the United States is 1.5, and 90% of that is potatoes in the form of either French fries or potato chips. So obviously we've got a long way to go if we're going to adopt a Mediterranean diet, but that's what it is. Fish at least twice a week or daily fish oil supplementation. Minimal red meat, no more than 4 ounces once a week. 4 ounces is pretty tiny. It's pretty tiny. Low-fat dairy. If you go into Greece, they don't have 40 grams of sugar with their yogurt. They have about 4 grams of sugar with their yogurt. It's a denser but lower fat dairy that they expose themselves to. Loads of nuts and seeds and beans and potatoes. There's something called the study for the aging that they've gone around the world and looked at people who've lived to 90 and 100. And one of the common things that folks have, and folks that are well cognating and are living to 90 or 100, they eat an ounce of seeds or nuts per day. Just if you take everything else out and equilibrate for all the other risk factors, they're big seed and nut eaters, interestingly. They're also very involved in their community. Those that are more involved with their families and their community have a substantially higher chance of reaching high cognitive levels in their 80s and 90s. It's a lot of olive oil, and they also drink a little bit of red wine. There's substantial data now for things like red wine and low-dose alcohol that can raise your HDL and lower your blood pressure. And it's more social probably, and people are more a little likely to kind of chat over the dinner table and not kind of disband and go and watch television for 3 hours and not talk to each other. Another study that just came out called the Dutch study, just released a couple of months ago, about coffee and tea. For a long while we were worried about caffeine. It's a stimulant. Oh, it's going to be terrible for your heart. Again, when they really looked at it critically, interestingly, if you're drinking 3 to 6 cups of tea versus a non-tea drinker, you've got a 45% reduction in the event rate. If you're drinking 2 to 4 cups or lower, you have a 20% reduction in the event rate. Start drinking 6 or 8 cups of coffee a day, your event rate actually starts to climb a little bit. Why is that? Well, tea and coffee, interestingly, have flavonoids in them. They're anti-inflammatories. Again, that same theme of looking for foods and beverages that are anti-inflammatory to our bodies. And then supplements are always, there's always huge questions on supplements. Everyone wants to cure themselves with non-medications. Well, these are medications. And they should be viewed as medications because there's several that have been shown to be negative. Vitamin E and vitamin A, which everyone thought were antioxidants. Again, we kind of rushed everyone to be on vitamin A. Then they finally decided to do the study afterwards, and they found that people on vitamin E and A replacement were having more stroke, more heart attack, because they're fat soluble. They accumulate in your liver and they cause toxic side effects. There's various things like St. John wort that can cause increased risk of cataracts. There's other things out there that increase risk of bleeding. And so they should be regulated. You should have a conversation with your physician about what you are on with supplements and not just willy-nilly start to doctor yourselves. But being as that said, there are several that have been shown to be very good. The biggest and best one that we know out there right now is fish oil. And fish oil, not flaxseed oil. Flaxseed oil is ALA or amino lavulinic acid, and fish oil is not that. Fish oil is DHA and EPA. I'm not going to try to pronounce those. But you need about 1 gram of those, and they can actually reduce your risk of heart failure, your risk of heart arrhythmia, and your risk of heart attack and stroke by somewhere between 20 and 25%, especially if you're a non-fish eater. Hard to get 1 gram of DHA and EPA. If you look at a lot of these containers, they only have about 500 milligrams. The way that I get it is by actually taking a teaspoon of salmon oil, because you get almost 1.5 grams in just a teaspoon, as opposed to taking 6 or 7 of these pills. Vitamin D we found to be extremely important, related not just to the bones, but to the heart. Interestingly, for many, many years, all you heard about with vitamin D was prevention of osteoporosis, but we know it's intimately linked to the development of coronary disease and heart failure. So, and at this latitude, they think that almost 70% of people are vitamin D deficient. And so get your vitamin D levels checked with your primary doctor and supplement. I'd almost say just supplement out of the box, because you only have a 20% chance of not having a normal level. CoQ10 has been talked about a lot. There's never been any study anywhere that has shown that CoQ10 helps prevent coronary disease. The only study that came close to showing that CoQ10 has some benefit was a study looking at people on statin drugs, on cholesterol drugs. It seems to lower their inflammation in their muscles. And so people that who are on a statin that start to ache on their statin, when I say statin, I'm talking about, you know, like your Lipitor, your Zocor, your Crestor, one of the ones that are lowering your cholesterol numbers. One of the potential side effects from those medications in some people is achy muscles. In those folks, if you take CoQ10 supplement, it does seem to lower that. But it doesn't intrinsically lower your risk of heart attack or stroke in and of itself. So future directions, where are we heading with all this? Obviously, in the last decade or two, genetic testing has become very important and popular and interesting. You can basically go out and almost have your entire genome or your entire DNA map just brought out in front of you. Unfortunately, what we don't know is what it means yet. We can say you have this gene or that gene, but we're not certain that it causes this or that problem yet, at least in heart disease. Because the problem with heart disease, it seems to be multifactorial. There's so many different interplay points, different intersection points with this stuff. It's not going to be a magic bullet that we just find one gene, turn it off, and there's no more heart disease. We know diabetes affects it, we know high blood pressure affects it, we know, cholesterol affects it. It's going to be one of these things where if you have these certain markers, you're going to be at a higher risk, so pay attention more to your risk factors. Well, we probably all ought to just be paying attention. We can kind of predate that. And currently available for genetic testing. We can look and see if some people are more prone to being resistant to blood thinners that we use for treatment. So some people are resistant to aspirin, some people are resistant to another blood thinner called Coumadin. So we can predict some of that now with some of the genetic testing. We also know that there are some higher risk cholesterol markers if you have what's called a C-reactive protein. That's a measure of inflammation. If that's elevated, we know there's some increased risk. We know that if your homocysteine level is elevated, we know there's some increased risk. And then there's some more advanced testing that looks interesting as well. CAT scans for calcium in your heart, ultrasound for thickening of the artery and the carotid artery. Not necessarily blockages, but actually thickening the artery wall also looks like an increased risk. So there's a lot of stuff burgeoning out there that's preventative, that's looking at trying to find people before they present with their problem. The Heart Association has been doing their deal trying to encourage recognition of this problem, particularly in women. We've got February is our big Women in Heart Disease Month. We have the red dress. You might see some of the cardiologists with the red dress pin trying to flash it up a little bit. And that's great, but I think what we need to do is the day-to-day, forget just February, but the other 11 months of the year to be proactive, talking to our neighbors. If you see someone that's obviously not taking care of themselves, be a community member and get involved in encouraging them to change their ways. Because ultimately, if not, they're going to wind up seeing me in the emergency room, and that's, again, the end of the line. You don't want to come to the end of the line. You want to be proactive with all this stuff. So that, I think, is the end of the slides. I'd be happy to take whatever questions that may have kind of come up as I rambled through all that data.